It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription, or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
I wanted to welcome you all back to the show and thank you all for listening. A lot going on. I have, in the coming weeks, some great webinars coming up. I hope you guys can join us. They're all given for free, and you can sign up at nrappain.org. Just click on the section for the conferences and webinars, or on the podcast show notes, I'll have a link. The first webinar is January 22nd, sponsored by Big Leap Health. We specialize in helping physicians treat patients, improve their bottom line with respect to providing Spravato, as well as transmagnetic stimulation for patients who have depression, and a lot of pain practices are adopting these procedures and therapies to help their patients, since we do see a lot of patients with depression, and improve their bottom line as well. In addition, they also assist with ketamine infusions for anxiety, depression, PTSD, and of course, chronic pain, which inspired my podcast topic today. That being said, we have another webinar for free again that is going to be given probably the first or second week of February. We're still hammering out the date with the Scrambler therapy, which I did a podcast back recently, and the company reached out, and I'm going to highlight their product on the podcast with some clinical data and talking to their team and experienced doctors who use the product, because this is something that there's evidence for. It's been around for a while, and it's treating something that's notoriously difficult, neuropathic pain. So I'm very excited to have them on the show. And lastly, I have at the end of February 26th, I'm doing my Claris webinar focusing on cervical spine ultrasound. And if you caught last episode where I was talking to Dr. Dos Santos from Spain, well, he's from Portugal, but he practices in Barcelona now. He's barely doing cervical epidurals interlaminar like myself. If you're doing interlaminar cervical epidurals, you can probably do a lot less by using the ultrasound and going for those selective nerve roots, and you'll be further away from the spinal cord. And if you know what you're doing with an ultrasound, I'm sure it's going to be a lot safer for your patients, because you're not going to be anywhere near the spinal cord. You're going to be using a non-particulate steroid, and you're probably going to get almost as good of a response. I say almost because I'd say about 10% of patients still usually need an epidural. And this is purely anecdotal. I have not yet published the exact stats on this, but I almost never need to do epidurals in my practice in the cervical spine, and my cervical radicular patients do great, and they very rarely need to see a surgeon. So make sure you check out these webinars. You can register on the website, on the nrappain.org website. You just go to conferences and webinars. They'll be on the calendar. And I look forward to seeing you there. I think it's going to be great. If you can't make it the live webinar, I'm going to put the audio on the podcast, and the video will be on the Pain Exam YouTube channel, which I'm always adding new videos to. And if you haven't checked it out, be sure to follow that, because I have a lot of cool videos for ultrasound, as well as my interviews with key speakers, faculty, industry, etc., over what's new and great in pain medicine. So speaking what's new and great, this is sort of new. It's from 21, so it's not that new. But it was an interesting paper on ketamine use for cancer and chronic pain management. So ketamine NMDA antagonist, it's a dissociative anesthetic, phencyclidine derivative. It does have some undesirable adverse effects, such as it can increase the sympathetic stimulation, increase blood pressure. You could have a bad trip, right? The K-hole, as they know. So it's not a perfect drug, of course. No drug is. But the whole, I guess, the interest in this drug really stems from its effects on NMDA and what it can do by possibly counteracting opioid-induced hyperalgesia. And it's a drug that's been around since the 1960s when it was first synthesized. It's a short-acting alternative to phencyclidine, which also demonstrated lower occurrence rates of emergence delirium. It was approved by the FDA for anesthesia in the 1970s, and there has been significant evidence that ketamine at sub-anesthetic doses provides significant analgesic effect with limited side effects. So we're using it as infusions for chronic refractory pain. And this article, which I'll have in the show note links, goes into all of the pharmacology, which I've done on podcasts in the past. I'm not going to spend too much time on that. But I will mention that the primary anesthetic effect of ketamine is associated with the NMDA receptor blockade, utilizing an uncompetitive mechanism with a relatively long knockoff time. Blockade of the NMDA receptors disrupts normal excitatory glutamate signaling in the CNS and is associated with many anesthetics. A depiction of the mechanism of action is in this article. You could check it out yourselves. There's also an inhibition of astrocyte activation, and this could be relevant because of the mouse models. Astrocyte activation can correspond to the development of neuropathic pain behavior. Meanwhile, minocycline, which is a microglial activator inhibitor, and pentoxifylline, a cytokinase release inhibitor, reduces the CCI-related hypersensitivity. And sorry, but for the life of me, I can't find what CCI stands for. Anyway, I don't really have time for that. You can look it up yourselves. The other cool thing about ketamine is the bronchodilatory effects, where you have muscarinic receptor antagonized by the drug with 10 to 20-fold less affinity than the NMDA receptors. And this is believed to help with pupillary dilation, bronchodilation, and this may be responsible for the roles ketamine has also with memory, consciousness, and learning. Anyway, back to the pain part. Increased use of ketamine in neuropathic pain has fueled research by indicating that ketamine may not only provide analgesia, but stop development of neuropathic pain at its source. And they have all sorts of mouse models to support that. So ketamine opioid-induced hyperalgesia, you can imagine, is quite useful, and there's more in this article about that. But I want to focus on the cancer aspect. So when it comes to chemotherapy-induced neuropathic pain, due to the frequency of chemotherapy-induced neuropathic pain in cancer patients, they did an animal modeling, 2 separate studies. Systemic ketamine injection ameliorated pain behaviors, including mechanical allodynia and thermal hyperalgesia in rats. And interestingly, one study found that a higher dose was required to significantly reduce pain thresholds in the male rats when compared to female rats. Interesting. Anyway, nerve-induced neuropathic injury. They did modeling with this as well. And interestingly enough, moving through this article, they actually give the definition of CCI later on as opposed to prior to mentioning it first, but it stands for chronic constriction injury. They also do constriction of the infraorbital nerve and complete transection of the spinal cord in animals for the model in rats. So they did single systemic injection of ketamine to reduce several nociceptive pain behaviors, including mechanical allodynia, hyperalgesia, cold analgesia, and spontaneous pain in the rat models. And they found that repeated injections or systemic infusion of ketamine reduced mechanical and cold allodynia for several weeks at doses of 9 milligrams per kilo per day for 5 days. However, a single systemic injection did not produce analgesic effects at a dose of 10 milligrams. In the chronic constriction injury model, systemic injections of ketamine reduced hyperalgesia and mechanical allodynia for several hours at a dose of 30, 40, and 50 mg per kilogram. So as far as diabetic neuropathic pain, not really a cancer thing, but it's in this article, they mentioned that they modeled this with mice, and in 2 studies, the streptozotocin-induced diabetic neuropathy, there was a systemic infusion of ketamine, 20 mg per kilo per day for 5 days, reduced heat and mechanical hyperalgesia for several weeks, and also had some opiate-sparing effects up to 6 weeks. So, and then there's more studies about other neuropathic pain. So, I mean, the bottom line is we kind of know this. There is some relief with ketamine. Here now they're mentioning IV infusions for chronic pain. And they did a meta-analysis of 221 patients in 7 different studies, revealed significant analgesic effect for IV ketamine infusions in both neuropathic and non-neuropathic pain when compared to placebo. The average infusion duration was 5 hours, and the average ketamine dose was 0.35 milligrams per kilogram. Now, the oral and nasal ketamine, which is getting us closer to Spravato, which is actually the S-ketamine, but still somewhat related. There's 2 studies investigating oral ketamine. Both showed at least mild pain reduction. One study was a daily dose of 2 milligrams per ketamine reduced or abolished pain in 2/3 of patients, while 1/2 patients reported some adverse effect. Only half the patients decided to stop the ketamine therapy. Interestingly enough, the incidence of adverse effects was lower in patients who are also taking opiates. That's interesting. In addition to reduction of pain, oral ketamine has been shown to promise in countering opioid-induced hyperalgesia, with the oral ketamine 0.5 milligrams per kilogram every 12 hours had significantly lower morphine consumption than the control group. So in the States, we're not really giving ketamine pills. I think in Canada they do that. Intranasal ketamine, although now more associated with treatment of depression, has also been used for treatment of cancer pain. After treatment with intranasal ketamine using a nasal pump spray, 65% of breakthrough cancer pain patients achieved a numeric pain intensity scale score that was at least 40% lower than pre-treatment levels compared to 20% of placebo patients achieving the same metric. Other studies of intranasal ketamine are scarce. However, the emergence of FDA-approved intranasal ketamine solution for other conditions it is possible that more studies will be done. Then there's topical ketamine. And there was a study with patients with CRPS, ketamine creams 10% only, and in combination with ketamine with other analgesics, found that as little as 30 minutes there was some improvement. And the systemic levels of ketamine remained undetectable. So there's a lot of cool things coming out there with ketamine. I don't think you're really being so on the fringe now if you're offering your patients ketamine. I remember 10 years ago, it was more kind of, I guess, just like PRP. It was more like, does it work? Is this just a way to make money? Is it real? But I think it's safe to say this is a real therapy. Whether reimbursed or not, this is a real therapy, a real tool in our arsenal. Just keep in mind contraindications. You don't want to really give ketamine to people with schizophrenia, psychotic symptoms, or PTSD. It's been shown to exacerbate or elicit psychotic symptoms in these patients. As well as when you're using with those patients, you might want to give it with benzodiazepines. And also caution with cardiovascular or hepatic compromise. Ketamine has been shown to increase cardiovascular stimulation, which could be harmful in certain patients. And it's widely contraindicated in patients with less than 3 months of age due to complications in maintaining an airway. So this is a therapy that I believe is here to stay. And there are lots of side effects that are listed here. I'm not going to get into all of them. I have to get my day started and treat pain. But I wanted to thank you guys for listening. And stay tuned. Check out these webinars. They're going to be really interesting. I'm really looking forward to all 3 of them. I mean, think about it. You have the Spravato intranasal ketamine, which I'm not currently doing, so I want to find out more about that. The TMI, the transmagnetic stimulation. That's also TMS, I should call it. That's also something that I think a lot of pain practices are going to be adopting because of the crossover. We do treat a lot of patients with depression, as well as ketamine infusions. Then, of course, scrambler therapy. If you don't know what it is, just Google it or come check out the webinar. You'll find out all about this therapy that is been around for over, I don't even know how many years, for a long time, but and there's evidence for it. It's just that I believe it's not reimbursed. Well, I guess we'll find out in the webinar, but just because things are not reimbursed does not mean that they're not useful or not indicated, hence PRP, right? And then lastly, learn ultrasound of the cervical spine at the Claris webinar at the end of February. And of course, I'm doing monthly or almost monthly ultrasound courses in New York as well as elsewhere. And you can set up a private course for yourself or your group at your location or mine. and I think you'll gain a lot from it and expand your repertoire of pain therapies for your patients and increase the safety as well. That being said, if you're around Dubai in April, I'll be at the Pain Expo. Otherwise, be sure to check out the Latin American Pain Society, ASPN, ASIP, and NICIP in the coming year. Thank you, and have a great day.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.